Okay, and we're back for pharmacological pain relief during active labor. And this is a big part of the labor and delivery nurse's job. It's good to know all the non pharmacological pain relief, but many women do get some kind of pharmacological pain relief. So, pharmacological management could start with narcotic pain medication or opioids, including nalbuphine, also known as Nubain, Stadol, Demerol, which is actually kind of out of favor. We're not using it that much, or morphine. In my practice, we used to use nalbuphine or Nubain frequently, and now I'm seeing more morphine. It aids relaxation and it provides relief from pain, but it does not remove pain entirely. A lot of times, women will still feel very uncomfortable at the peak of the contraction, but maybe only for a few seconds. And then they go to sleep in between contractions. It wears off relatively quickly, somewhere between 2 to 4 hours. People are usually uncomfortable again. And it may mask changes in the fetal heart rate pattern. Usually, what we see is decreased variability with opioids, and then you're not sure whether the decreased variability is because of the opioid or because baby is losing that reserve, which should not be given late in labor. This is a big test question, so know it. It should not be given late in labor because the baby is also getting some, and we know that opioids depress respiratory drive. So, being that they've never, breathed the outside air before and they're new at it, they might not start breathing right away. So, if you do give it late in labor, it's better to have a resuscitation team there. But generally speaking, if a patient is 8 or 9 centimeters, this is not the best option. It does increase mom's risk for falls, so tell her not to get out of bed without you. And then we have nitrous oxide. Nitrous oxide is also known as laughing gas. It does not necessarily reduce pain. What it does is it assists and facilitates coping. So what moms will say is, I felt pain, I just didn't care. It's really good for people who cope well with labor and just need a little something to help them decrease anxiety and relax a little more deeply, which itself will reduce the sensation of pain. It does not have systemic effects on the fetus. Minimal maternal side effects. Some women will feel lightheaded. If that happens, you just tell her to take the mask off, and it's easily reversed by breathing room air within seconds, and it's out of her system. It increases a maternal sense of control during labor. So it is a good option for some women. It's not the best option for someone who does not want to feel pain. Okay, pharmacological, moving on. Epidural, this is like the Cadillac of pain relief. It's medication injected into the epidural space. This gives superior pain relief. People are, generally speaking, numb from the upper abdomen all the way down to their feet. It can be bolused for a C-section or if there's breakthrough pain. But it does impair motor and sensory function. I have heard of walking epidurals, and in Britain they're very common. They use a very low dose, and it does not decrease pain as well. But generally speaking, in America, women do not get out of bed and may need urinary catheterization because they lose sense of the urge to void, and their bladders can get distended. Side effects: hypotension. I underlined it. I bolded it. I put 3 exclamation points because it causes vasodilation and relaxation. And that hypotension is going to make mom feel bad, but it's also going to decrease uteroplacental perfusion. So we call that an epidural plunge when the baby's heart rate just goes boom down to the bottom. So watch your strip after you give it. Really, we have to bolus them with fluid beforehand so that they don't have that severe drop in blood pressure. Sometimes epidurals actually make labor go better because remember your 5 Ps, mom's psyche, she's more relaxed. Sometimes they will slow labor progress because mom is not up and moving and it's a little more difficult to position her. So it's a little hard to predict what the effect is going to be. Care of the woman receiving epidural anesthesia will be to educate the patient on what to expect. The epidural does take away pain. It does not take away pressure unless it's too heavy. So she should still feel the urge to push, and at that point labor might become more uncomfortable again. She's going to need fluids, at least a liter. And you're going to assist with positioning, and it's called the angry cat position. The woman is sitting with her back to the anesthesiologist, and her back is curved out like the letter C or a shrimp or that Halloween cat. Think of the cat-cow position in yoga. That's how you want her to be. You want to open up those vertebrae as much as possible because the anesthesiologist or nurse anesthetist is going to have to get into a tiny space and it's a blind stick. You're going to minimize the risk of infection by wearing a mask and a hat. That prevents droplets and any kind of bacterial infection. Monitor mom's vital signs. In the beginning, you're going to take the blood pressure like every 2 to 3 minutes, then every 5, then every 10, and then every half an hour. Dermatome level, I'll show you in a minute. That's the level of the spinal cord that corresponds to the anesthesia. And you're going to watch that fetal heart tracing again for that epidural plunge. Assess the bladder regularly for distension. And sometimes mom can use a bedpan. More often than not, though, she will need a catheter. This is that angry cat position that I'm telling you about, and this is where that needle goes. And you can see they thread a very tiny, almost like an IV catheter, through that space, and the medication is infused here. Okay? Dermatomes chart. I told you I would show you the chart. So usually you want a level of anesthesia that's about T9 or T10. That's going to be what takes away most of mom's pain. The way that we assess dermatome level is we show mom on her arm, this is an alcohol swab, it's cold and wet. And then I give her something a little bit scratchy, like a blunt needle, and I say, do you feel how that's sharp? And she'll say, yeah. And then I go around T9 and I start there. I say, what do you feel? And if she can't tell me whether it's wet or dry or sharp or soft, then I know she's still feeling at that level. I'll go a little bit lower to T10, T11, wherever. Good epidural will be about T9 or T10. And that's where we break for that video.